Our next speaker needs no introduction, so I won't introduce him. But I will for those living under a shell. That is Professor Javed Iqbal Farooqi. He's the ex-president of the Pakistan Society of Hepatology and one of its most energetic members. He's the former head of department at the Lady Reading Hospital in Peshawar, and he has decades of experience in managing patients with liver cirrhosis. At this point in time, I would like to mention a movie called Redbeard by the legendary Japanese director Akira Kurosawa. And that is a movie I tell all my residents to see because it instills a habit of empathy in anybody who wants to practice medicine, because one needs to go beyond just treating disease and one needs to look at what deeper issues that a patient and society might incur on a particular individual who is suffering from a disease. In a society like Pakistan, which is unfortunately where liver disease is pandemic, and as per many studies that we have done, nearly 70% of people find out for the first time in their life that they have liver disease when they have already developed a complication of cirrhosis. It is a very complicated challenge. And this experience, this rich experience that Dr. Javed carries in managing such patients and looking into things beyond just ascites and portal hypertension and encephalopathy and countering SBP, looking into the deeper social and economic and other issues that these humans might face, because at the end of the day, it is a human. That experience is unmatched. So I would like to call Professor Javed to come on stage and share his experience of managing patients with liver cirrhosis.
Thank you, Dr. Adnan, for such an elaborate and kind words. Well, greetings from Peshawar to all of you, Professor Kao and Professor Maria and Professor Rafael. Next time when you come to Peshawar, we will really serve you with this traditional food, what we are having. Well, the topic of, or the theme of this conference, this session is a case-based review and essentials of hepatology from guidelines to practice. So in the next 18-19 minutes or so, what I will do to give you the essential points of liver care, which the guidelines want. Please don't be afraid, I won't go into the details of the guidelines or all those things. Yeah, okay. In the audience, may I have, how many PGs are there? Can you raise your hands? PGs. Because my stuff doesn't is for you as well. And primary care physicians, primary care. Oh well, that's wonderful. Young consultants, just our young consultants, like sitting over there and like there. Yeah. Well, and the faculty, you will help me out when there is question answer session. So the topic which has been given to me is the challenges in the management of decompensated liver patient, and as I said, case-based scenario. So I thought that I will share with you the case-based. 47-year-old man who presented with recurrent episodes of hematemesis in melena for last one day. In the ER, his BP, he was drowsy, pulse 110, BP 90/50, temperature 105, and mildly jaundiced. There's a past history of cholecystectomy 13 years ago, when he was found to be having anti-HCV positive by ELISA. He's diabetic and hypertensive and goes to his doctor whenever any problem arises. Otherwise, it doesn't make any regular visits with his doctor. His previous medical record shows mild course echo pattern of his liver with mild splenomegaly, an ultrasound which was done at the time of cholecystectomy. His PCR has never been checked. 13 years passed, his PCR has never been checked. And on examination now, he was comatose, jaundiced, anemic man with clinically moderate ascites, ultrasound showing small shrunken liver, dilated portal vein, splenomegaly of 18 centimeter, splenic varices, moderate ascites, and 3.4 centimeter SOL in his right lobe of the liver. This is his ultrasound when it was done. He was admitted to HDU or intensive care unit. Protocol of comatose patient initiated, stabilized hemodynamically, started an IV broad spectrum antibiotics, telepressin with fluid monitoring of any possible ischemia. He's hypertensive or diabetic. Ensured proper bowel emptying because he's drowsy in hepatic encephalopathy, grade 1, grade 2, and transfused 2 units of packed cell volume. Next day, EGD was done. 3 columns of moderate to large size esophageal varices with the esophagogastric varix 1. No active bleeding at the time of endoscopy, but esophageal varices showing ERS, EVBL done. Patient stabilized over next 8 days. Discharge on diuretics, carvedilol, lactulose, rifaximin, and oral antibiotics. Advised to come after 4 weeks of follow-up visit. PGs. How many of you come across this scenario in your practice? And how frequently? It's almost the every week history, if not every day, if you are not GI. So this is what we see in our setup. And in this history, I will just share with you that, well, whether this is a decompensated or early stage, what is the essential management for such patients, and what are the challenges and how to overcome these. Because this case history provides us the basis for all the discussion which I have been asked to do with you. So first take the decompensated liver patient, how we diagnose it. We all know the history or the findings here. Hematemesis melina, which has been read in colored in red, drowsy, being itchy, moderate ascites, having SOL, esophageal varices, showing ERS. All these are the signs and symptoms of decompensation. So he is a decompensated liver disease. We all know this is the basic. Please do remember this picture, because I will develop my whole talk. Whether it is the viral causes, non-viral causes, cirrhotic liver means altered anatomy and loss of function. We all know that's very simple. This is especially for PGs. We know life cirrhosis is a lifelong disease. It's gradually worsening, associated complications the cirrhosis has, and if no intervention done, it is lethal. It is, we can say, the term cancer. It kills the patient. So, again, for my PGs and primary care physician, the chronic liver disease, the patient will be having no cirrhosis, that is the early chronic liver disease, but the patient has got advanced chronic liver disease, which is called cirrhosis. Please remember these 3 coding, the blue, the green, and the yellow, because on the basis of this, we will refer to these again and again. Why we say the compensated, or when we say the compensated or decompensated, compensated means when the patient has not developed varices and no ascites. This is the first stage of compensated cirrhosis. But if a patient develops varices but no ascites, still this is the compensated cirrhosis, but the second stage. If a patient develops, well, it's not only the decompensation doesn't mean only the ascites, variceal bleeding. It may be hepatic encephalopathy starting from the above the variceal bleeding, ascites, HCC. The early stage of HCC is in the sorts of decompensation, not the terminal one. Infections, coagulopathy, and malnutrition. All these are the different sorts of decompensation which your patient can have. But what will be the terminal stage of this patient? If the ascites has the SBP, spontaneous brittle peritonitis, becomes refractory, or HRS develops, the HCC is in advanced stage, or the patient develops acute and chronic liver failure, this will be the terminal stage of your cirrhotic patient unless transplant is done, and if that is feasible, the patient is going to die in months' time. So you should be remembering that what the my patient fate is. So this was the decompensated patient and how the decompensation goes long way. Coming to the management. Well, in the same history, the points which has been shown in red, HDU admission, protocol of the comatose patients, antibiotics, treleprosine, the proper bowel cleansing, AVBL, and all these are the components of the management. And believe me, the management of a decompensated chronic liver disease is not a single man job. You need a team. The essentials of team are definitely hepatologist, endoscopist, interventional radiologist at times, intensivist when you admit this patient in the ICU, like this one, hepatobiliary surgeon may be needed, and above all, the supportive team, your nursing staff, your ICU team. These are your junior team. These are very, very important for these patients. And remember, any decompensation even means three sorts of therapies. The red one is to treat the primary decompensation, whether the patient is presented with a bleed or a ascites or encephalopathy. Then, like in this patient, the patient had bleed, then he developed the sorts of coma, hepatic encephalopathy, because of the high volume of blood in the gut which was absorbed, and that was a high protein diet for this patient. Then this is a comatose patient, can do aspiration. He was having ascites, he can go into hepatorenal syndrome. So three main components. One is treat the primary decompensation. Second, treat the secondary compensation. Third, treat the preventive strategy, so another complication does not happen. So this cascade or the sequence of the management will be acute event, implying three types of therapies: primary decompensation, treating secondary decompensation, and preventing the tertiary complications. Then do the secondary prophylaxis. Suppose a patient had bleed, so you imply the treatment, you give the treatment to, so another bleed doesn't happen. As like in this patient, carvedilol was advised and he was asked to come after 1 month, so a recheck endoscopy will be done, and if there is varices, that will be rebanded again. And then preventive prophylaxis for those complications which have not happened. The third essential component of decompensated patient management is arrest the inflammation or treat the etiology. Like in this patient, no PCR was done, we didn't know what was the viral status. Keep the patient in CTPA, ensure desirable nutritional status, prompt and effective control of infection, avoid hepatotoxic drug, this is very, very important, and surveillance for HCC, and of course vaccination against hepatitis B if the patient is hepatitis C, hepatitis E, and other vaccinations. These are very, very important. So, now coming to the challenges which I have been asked to talk about. These are the points. You see, 13 years ago this patient was diagnosed. He was found to be having anti-HCV, but still no workup was done. Delayed diagnosis. He was diabetic, hypertensive. The doctor should have asked you are at the risk of developing cirrhosis. You should be having a proper monitoring, follow-ups. No follow-ups, no monitoring. Then the complications happen that it could have been preempted and prevented. Prophylactic therapies could have been done to that patient. And the blue are the management which has been given to him when the patient was being discharged. So, the challenges in the management of decompensated liver patient is, number one, lack of in-time diagnosis of chronic liver disease. This is what I see in clinical practice, that these patients are diagnosed very, very late. Lack of proper monitoring of chronic liver disease patients. They are labeled as chronic liver disease, but no proper monitoring is done. This is again very important. Lack of proper prophylactic strategies. These are not implied in across the board in each and every patient. Lack of preempting of decompensation. We don't preempt that this patient can develop the risk of some complication, some decompensation. We don't preempt. Lack of properly trained and dedicated team in most of the centers. And of course, there is no culture of this MDT strategy. When we have specified MDT to the cancer, it's not only for the cancer. When the liver transplant is not an option for each and every patient, you need a team here for that very patient. This is very, very important. So how to overcome this? Lack of in-time diagnosis. This is very important. We must, for high-risk patient, clinical features of cirrhosis. If there are no clinical features, ultrasound can tell you, labs can tell you. If the ultrasound is normal, still your patient can be cirrhotic, and then at that the FIB4, APRI and FibroScan can help you, can tell you whether your patient has got advanced fibrosis or not. This is very, and these are not very costly tests, the FIBRI, APRI and FIB4. These are smartphone based scores and just needing your ALT, AST, age and platelet count. Then lack of proper monitoring. But I see that these patients are not properly monitored. CTP score and MERS score, again very simple scores, smartphone based scores, and these patients can be monitored just like you monitor diabetes by doing regular blood sugars and HbA1c levels. You monitor your hypertensive patients by doing taking serial blood pressure levels. So the monitoring is the lifelong monitoring for chronic liver disease patients. CTP score is the best tool, and we know if our patient is in child class A, the patient has best survival, but if the patient is child class C, survival is half to or even less than that. Similarly, MELD score, it tells you the 3 months mortality, and by every increasing the 10th score, the mortality triples. Like in 6 to 9, 3 months mortality is less than 2%, but when it is 10 to 19, it is 6%. When it is 20 to 29, it is triple than that, almost 20%, then 60%. We do know that hepatic venous pressure gradient is the main culprit, but we don't check it clinically, we don't do it clinically. Important point is, if our patient is in child class A and is a good MELD, the patient has got favorable or desirable hepatic venous pressure gradient. If my patient is cirrhotic, chronic liver disease, I cannot say that my patient portal hypertension should be normal. There will be portal hypertension, but it will be within desirable limit. So, this was another way how to overcome the second challenge, prophylactic therapies. We must ensure that our patient gets primary prophylactic measure, the secondary prophylactic measure, because until we do these, probably these patients will be developing the complications. Like this patient developed complication, he was not in time diagnosed, no properly management was done, no prophylactic measures were done, and the patient he just developed the bleed, the hepatoma, and the ascites, and the HE. So this is the result, that because he was not properly monitored and no preventive measures, prophylactic measures were given to these patients. So coming to the preempting decompensation, this is again very important. We should preempt the decompensation. We know the fate of a cirrhotic patient is decompensation and needing cirrhosis, liver transplant. Decompensation is, one is the natural slow decompensation of these patients, another is the fast track decompensation. And the fast track decompensation is when the patient develops HCC or ACLF. So this is very important, we should preempt. And how we should preempt, coming again to that slide. When I say no cirrhosis, this means portal venous pressure is normal. When I say it is cirrhosis, it means there is portal hypertension. And again, it is divided into insignificant and clinically significant. Insignificant is when there is no varices and no ascites, and it is 5 to 10. But when it is more than 10, it is clinically significant. But again, it is divided into 2, 10 to 12 when the varices develop but they don't rupture, and more than 12 when the varices rupture. So this is important. Remember these figures in your mind. And these are very simple. You don't need to do the HPVG. Most of the time, these are very well correlating with your APRI and FIP4 scoring. This is very, very important. Even the transit elastography which you have been done, again, this APRI and FIP4 M4, most of the cases, they do correlate. I'm not saying 100%, but they do correlate. So please do these two tests. These are very, very important. Remember, the HCC may develop in compensated cirrhosis. It's not immune. It do develop, but when the patient is decompensated, it does develop. It does develop. Similarly, HE. In the no cirrhosis and compensated cirrhosis, HE develops as a result of ACLF. You need some hit, some insult to the liver to give you HE. But in the decompensated, the HE develops as a consequence of your liver cirrhotic patients. So you must see where, in which place my patient is, because if you know that, you'll plan for prevention of all these complications. And the platelet also tells you. So just last 1 minute, please, I'll take that. The lack of properly trained and dedicated team, we do need that. These patients need indoor care, outdoor care, and even the home care. In the home care, we don't need that we should be sending our patient, our staff. We can train their attendants, some educated person over there. This is very, very important. And when we train them, they can take care of that patient very well. Lack of MDT strategies, again, this is lacking. We must develop this culture. So I will just, this was just, we had shared our data. Most of our patients there are because of HCV. More than 50% of our patients, it was almost 3,000 patient data. It is in child class A. So remember, if you apply these measures, you can help these patients. You can help these 50% patients. They are in child class A. There's a hope there. They have got good MELS score. It's hope there. Please do imply these measures. And this was the different complications. So to sum up, dear Chairman, this creature is a very delicate creature. You need extra care for this creature, the cirrhotic patients. They need your extra care. Very, very. Liver cirrhosis has well-defined natural history. Cirrhotic patients must properly be monitored over time. I am stressing this again and again. Decompensation must be preempted. Success lies in the team approach. But never forget to explain the disease and its expected course to patient and relative. This is very, very important. We don't explain to them what you are afraid of, what it is going to happen, and to avoid malnutrition in cirrhotic patients. This is very, very important. Please don't forget the last 2 points. In this, I stop here. Thank you very much. Sorry for that electricity inconvenience, but the things happen like this way. Thank you very much.
Thank you, Professor Javed. Thank you for clapping. Woke some people up.